David, thank you for being invited to speak at the CCR-Expo again this year. I enjoyed my talk last year, and I've been asked to talk this year from a non-surgical perspective. I really should disclose that I'm not speaking on behalf of any organisation or association I'm a member of. These are purely personal views that I'm going to be sharing with you. And I was asked to speak on my views of that divide between aesthetic medicine and surgery. And a lot has changed. Time was, maybe 20 years ago, that the consultant was an omnipotent being who walked into the hospital. Everyone fell quiet. No one dared question his, because it was usually a him, his decision-making, albeit if that was slightly uncertain or perhaps even dangerous. And we can all recognise nowadays that that wasn't a great model, that pyramidal hierarchy, where no one would question what the consultant said and what the procedure was. And nowadays, of course, things have evolved greatly since then. And there's a much flatter hierarchy. Indeed, I think the hierarchy can sometimes be so flat, it's hard to distinguish who the consultant is when we look at a group of practitioners, doctors, nurses, and other allied specialists. And sometimes the consultant needs to be pointed out rather than making themselves obvious. Now, alongside the change in the culture in medicine, that is not only in the UK but abroad as well, there's been an explosion of techniques that have come onto the market, as we all know, and as this conference is testament to, especially within the non-surgical world, whether it's through devices, through injectables, or through minimally invasive techniques. This has happened alongside this flattening of hierarchy. And in parallel with this, there's also become a much more of an open market as to who can deliver these devices, deliver these injectables and other techniques, which were once perhaps the sole domain of plastic surgeons with perhaps dermatologists. And of course, we're all aware, and it has been debated earlier, about the lack of regulation in this market. But unfortunately, what this has led to, certainly over here in the UK, is rather than a collaborative work ethic, it's more of a confrontational work ethic has sort of developed because of the tension between the cosmetic physicians, cosmetic doctors, perhaps cosmetic nurses, and plastic surgeons, each feeling that they have an absolute right to be doing what they're doing over and above the other. And really, I don't think any of us in this room would agree that this is a really very helpful way of approaching what we do for the benefit of our patients. We're all here to stay. Cosmetic doctors, cosmetic nurses, dermatologists, plastic surgeons, we all exist, we're all going to be here to stay. And surely it's better for our patients if we can play to our strengths, work collaboratively, and really take on the model that has been established ubiquitously in hospitals now in different specialties of a multidisciplinary team and a way of working. Because I think we're very much at a crossroads where we should be working collaboratively rather than competitively in a multidisciplinary team network, whether that's real or virtual. And at the end of the day, as I said, we're all here to stay, whatever discipline we're in, and we are faced with an ever-aging population, an increasing expansion of the popularity in the treatments and techniques we offer, and therefore there should be a way of working together for the benefit of our patients. So I've put my foot forward first because I believe so strongly in this, with the development of what is effectively an aesthetic polyclinic, where I work alongside another plastic surgeon, maxac surgeon, cosmetic doctor, specialist nurse and others in a collaborative way in which occasionally we'll see patients together. We'll certainly cross-refer and cross-pollinate with each other, which the patients in their feedback has unanimously praised our approach and the way we take things. And really I would like to think that anyone who practices, whether as a surgeon, dermatologist, cosmetic doctor or nurse or other, would have a network, and if they don't have one, would form a network to be able to give their patients the same sort of breadth of options. Because it's a journey, we all get older, there isn't a one-stop shop for any particular treatment. People may start off having toxins, may have Botox, they may then come on to having an upper blepharoplasty once the toxins aren't performing to the extent that they want. They then may have other skin treatments, because that's, of course, part of the whole anti-aging package, before they may reach the stage that they might have a facelift. And even if they do have a facelift, they've then got to have maintenance, whether it's with further toxins or other non-surgical treatments. And each of us can play a role in this journey for the patient, which is ongoing and continuous. Because to get the optimum outcome for a patient, the combination of aesthetic medicine, aesthetic surgery, and advanced skin treatments really needs to be tailored for the individual. And surely I'm preaching to the converted with an audience here. So, what is the best way to achieve results? We've got our slightly tired, sad, unhappy looking patient on our left and our bright, rejuvenated, well-treated patient on our right. And perhaps everyone in this room would have a different way they might decide to treat that patient, whether it's through non-surgical, laser, or surgical means. And actually, just out of interest, I'd be quite interested in a show of hands of people personally who could treat with peels or injectables in this room. So predictably, the majority of people could do that. Laser resurfacing, how many people personally could laser resurface? So it's predictably, again, a smaller number. And then finally, how many people could perform periorbital surgery or a facelifting? So yeah, a smaller number. I mean, clearly, I was speaking in a non-surgical conference, so that was slightly predictable. But of course, as we go into more invasive treatments, there are fewer practitioners who can perform these, and it is perhaps not appropriate for those who are not performing a lot of any individual procedure to be doing them all the time. Rather, they should be referring on to those who do. But what's right for the patient? Well, it depends, and it's different for every patient, of course. It depends on their downtime they're prepared to accept, the financial cost, what their budget is, what their expectations are, what compromise they're prepared to make, and also what the outcome of the procedure that they are prepared for or desire. And only by weighing up that complex equation can we really give a good choice to the patient. And in our calculations of what the right choice for the patient, we should also weigh up those treatments that we don't personally offer ourselves. So I'm just going to digress just for a minute to talk about the work of Daniel Kahneman. I don't know if any of you have come across him, but he is a very pioneering and groundbreaking psychologist who pretty well single-handedly developed the sphere of behavioural psychology and advanced our understanding of decision-making, and this affects all of us in this room with respect to decision-making about treating our patients. And he was the first to understand and show quite equivocally that decision-making and how we reach decisions, whether it's decision-making in terms of treatments for our patients or whether it's choosing which device we may want to buy for our practice, is not to do with the evidence presented, it's to do with the coherence of the story that the mind has managed to construct, i.e. our emotional feelings about it. We don't think objectively, we all think subjectively. His work was so groundbreaking. Here it can be seen awarded the Nobel Prize, but his Nobel Prize wasn't in the field of psychology, it's actually in the field of economics because of the impact he had on the understanding and the changing face he was able to provide with how economic theory was impacted on. So what he came up with was an understanding of biases and heuristics, so-called mental shortcuts, and an understanding of how the mind works and how we make decisions, but the fact that these decisions are prone to significant error. And what's very relevant to us is we're all biased to think of options that we have more exposure to, the ones in our armamentarium, the ones that we have in our practice, or also the ones we've heard about recently. So the old adage that beware of the doctor or practitioner who's just returned from a meeting because they'll be trying out new things for the first time, has its base in this sort of background. We can't completely avoid it, but if we have an awareness of it, it will help minimise our exposure to its effects. So, to digress again slightly, yes, there are several options to treat your sun-damaged skin. I'd recommend rhubarb peel. He's just seen the rhubarb peel at the CCR-Expo. He's got no other treatments available to him at the time. He doesn't actually consider an alternative, and more worryingly, he rapidly convinces himself this is the best advice. And that's really the concern there, because the narrative we create for ourselves, which would quite often be one in which the advice we've given is that we can deliver ourselves is the danger zone. To summarise that, if all you have is a hammer, everything looks like a nail. So was that the best advice to give to the patient? Maybe it was, but there's a good chance it wasn't. So going back to our dour, sad and tired-looking Barbie, compared with our rejuvenated, fresh-looking Barbie, what is the best way to get there? Well, we already realised that it's a complex equation dependent upon the individual patients, and we have to be honest with our patients, of course, be realistic, and if there are uncertain outcomes, and of course we should all be aware of the uncertain nature and the void of long-term data with a lot of devices that are out there and a lot of the other anti-aging products that we're being presented with on a daily basis. As long as we're honest with our patients of what we do know and what we don't know, and what we can offer and what others can offer, then I think we've got a good way of going forward. So what would my feeling be that we should do? Well, I hope if there are two take-home messages from what I'm saying, I'd like everyone to be aware of the limitations and the scope of their practice and whether they feel that every time they encounter a patient, they should perhaps be considering other alternatives that they may not be able to offer themselves. Be honest about your outcomes, but also be part of a network or MDT, and that network, whether real or virtual, should, in my opinion, include a plastic surgeon, a dermatologist, as well as a cosmetic doctor and nurse, at the very least. And I mean, that's a challenge. It's a challenge to maintain excellent working and personal relationships within the team to avoid the risks of bitter jealousies and rivalries coming to the fore. Why do we need to do this? Well, really, I think it's beholden to all of us to do this because we have trusting, vulnerable and loyal patients who would like to have a long-standing relationship with us. And we're the ones who have the authority, the power, the expertise, and really should be honest about the whole scope of our practice and how we expose ourselves to the patients. And please, I implore we don't, any of us, end up going down this direction where people lose insight of their capabilities and perhaps an aesthetic compass and end up doing things that are really disastrous for their patients. So I hope we can all work collaboratively, as this conference is testament to, and take things forward for the benefit of our patients. Thank you.
Thank you very much for that, Mark. I think we're going to take questions at the end.